Okay, good morning, everybody. We were so close to wrapping up this chapter. Uh, but I get to fungal stuff and I'm just like, holy cow, there's so many things that I'm just like, oh, I love these. All right, I don't love athlete's foot, but I think some of the fungal infections truly are fascinating. And as we shift over to the uh next chapter with respiratory infections, there's some more fungi that we will throw into the mix. Okay, so I know we talked about the tenias, and I mentioned that initially they're named this way because the appearance made them believe that they were a type of worm, but truly we're talking fungi. There are lots of players here, and we'll see in a second a number of genera and handfuls of species within these genera that can cause various cutaneous fungal infections. And oftentimes we give them names based off of body sites where we may see them. So kind of just depends. Cultivating fungi is similar to cultivating bacteria, but it appears very differently. It also depends on the type of fungus that we're thinking about. If we're thinking about molds, filamentous fungi, their appearance is very different than looking at bacterial colonies, fuzzy, all sorts of varied colors. And oftentimes, when we think about cultivating these, we look at the top of the plate and we also look at the bottom of the plate, the underside of the plate. And you'll see fuzzy, typically, fuzzy growth and maybe some coloration as a result of some of the spores that these guys are producing. And underneath, likely different sorts of colors, and they don't have roots, but it kind of looks like root-like structures, almost very different as they're degrading that arbor plate. All right, they're really feeding on some nutrients, but they can break some more stuff down. All right, it makes it look different for sure. Bacteria aren't eating the auger, right? But the fungi, it's a little bit different. Yeast cells, they look a little more bacterial like as far as the colonies go. They're different, but they're not fuzzy looking. All right. So these are, this is one of the dermatophytes. So filamentous type of fungi, Trachophyton rubrum. Uh, if we were to zoom in, maybe slap this plate under a dissecting microscope, we could see all of the little strands, the hyphae, and we could see some of the spore structures with that mold. And that's a lot of this inner bit, this discoloration. So we grow fungi on agar plates, but we use some specialized media. And we've talked about all sorts of different types of media, really thinking about growing bacteria. For fungi, one type is called sabarode, and it is a type of media that is more selective for fungi. There are some substances, potentially substances added, antibiotics, antibacterial compounds that help to ensure that all we're really growing is fungi. All right. Maybe in the lab, you saw some of the plates before you inoculated them that maybe had a little bit of fungi growing on them. Sometimes the plates, nutrient agar plates, they pump out mass quantities of nutrient agar plates. We've got almost 150 people rolling through these labs almost every single semester. Lots of people, lots of nutrient agar. So they pour liters of media, and some of that potentially ends up getting contaminated as it's chilling in the fridge. We try, hard to make everything as aseptic as possible, but sometimes mold spores are all over the place. And in the process of pouring these plates, maybe something starts to grow in there as it's chilling in the fridge for a little bit of time. The nutrient augers, all of these other plates, they're just let stuff grow. Molds, bacterias, whatever it is. And in those instances, we technically don't want mold growing on it. But these plates, it's really what we're hoping for. All right. And based off of some of these observations might clue us into who we're really looking at, colors and morphologies like that. There are other types of media that we also might employ, depends on the type of fungus that we're dealing with. All right. While we're still thinking cultivation, I also want to throw out, dependent upon what sort of infection we're thinking about, we may potentially cultivate at different temperatures. There are some fungi, and we're not thinking our dermatophytes, but we will think about these in the next chapter. Some fungi that we call dimorphic, and they may grow in the environment as a mold. Often that's what we see. And then those mold spores potentially get inhaled and they convert into yeast cells. Two different temperatures from the environment to a human body, and cultivating them at room temperature, 25 degrees Celsius, about 70-ish Fahrenheit, or 37 degrees Celsius, our body temperature, gives us the opportunity to see if this type of fungus is a dimorphic one, if it can grow at both of these temperatures and give us different looking appearances. Interesting. All right. So we don't think about that with the dermatophytes, but we'll think about some more stuff coming up. So this next one, a type of mold called Aspergillus. There are a handful of species of Aspergillus. This is one that's typically described as one of the black molds. The spores that they're producing gives them that appearance. And oftentimes they're observed in areas that, like maybe a poorly ventilated bathroom, something like that, where the fungi has the potential to take hold and is in a habitat that's really pretty suitable for its growth. All right. So there are a handful of situations when we think about this for infection with Aspergillus. Oftentimes we think about inhalation of the spores and a pulmonary infection. We'll talk about it in the next chapter. All right. But there are opportunities, as we see here, thinking skin stuff. There are opportunities for the fungal infection within the lungs to disseminate and result in infections elsewhere. So this is a secondary cutaneous aspergillosis. And we say secondary because it initiated in the lungs, all right? And then ultimately through dissemination presents on the skin as these lesions, all right? So there are also opportunities to see this without the pulmonary infection. And in that instance, we wouldn't call it secondary. It would just be cutaneous aspergillosis. A direct inoculation of the fungi into a wound could result in this. So the terminology is important to think about, where's it ultimately coming from, all right? And deep down, my gut says secondary cutaneous aspergillosis is worse because you've got the underlying pulmonary infection and then the organism coursing through the body, all right, to result in this. So, like I said, handfuls of different species within this genera, and there are others that also could be described as some of the black molds that aren't aspergillus. But as far as potential issues, it definitely is a concern. Some of the sick building syndrome stuff can be the result of fungi. Other things might be chemicals like formaldehydes and things that might be in the building materials that can result in issues. But sometimes it's the fungus, right? So this next image, another Savarode plate shifting over to frame C. Candida albicans are yeasts. And so these yeast cells growing on this plate look very different than that trichophyton that we looked at initially, all right? Kind of a little more bacterial-like sort of colonies, all right, as you look at them. The yeasts, if we were to take a little bit of this and stain it up, we would see large, kind of oval-shaped yeast cells with, dependent upon the type of yeast, thick or thin cell walls surrounding them. And the way it stains up can kind of clue you into the cell wall properties a little bit. So there's a lot of potentials for Candida to cause infections. Oftentimes, when I think about this yeast, I think about yeast infections. I think about issues with taking antibiotics and setting the stage for some of these yeast cells to proliferate. That's the main thing I think about. It's the same idea like thinking about Streptococcus pyogenes. I think about sore throat before I start thinking necrotizing fasciitis. But there's potentials, all right? So we will think Candida a little later for other issues. But with the skin, there are potentials for cutaneous candidiasis. We can see that here. We can see other issues like your nails that can have either dermatophyte infections or yeast infections that can cause issues in the nail. All right. So trichophytins and others, microsporium and epidermophyton, those are the three main players with the dermatophytes. We'll show you that in a second. Or candida, all right, that can cause some of these issues, all right? And with that, a quick list of some of these. We didn't talk sporothrix, but we've seen the image of sporothrix previously, and I said we ought to transplant that image over here because it fits within the skin infections. So sporothrix, as opposed to artenias, is more of a deeper fungal infection, not just in the epidermal layers of the skin, but going deeper into the dermal layers, causing greater issues. If you remember the guy's arm all red and inflamed, sores, lesions, ulcers, all sorts of potentials with this. All right. So for the aspergillus, aspergillosis is the infection, and fumigatus or flavus are the two species of that. And you can see those lesions, the eschars, at the site of infection. So it could be, as I mentioned, primary as a result of a direct inoculation or a dissemination as a result of the pulmonary infection. And we'll talk about details with it as we move into the next chapter. All right. There are all sorts of antifungal agents that we think about as potentials to treat various fungal infections, whether it be cutaneous or systemic sorts of infections. Some of these are the same sorts of players. We will also see a handful of these drugs with utility with some of our parasitic infections. Protozoal organisms can be treated with some of these antifungal agents as well. All right. So there are some issues with these in the fact that our fungi and the protists, they're eukaryotic, just like our own cells, and treatment becomes more of an issue as we're trying to combat these cells. It's also something that's typically more prolonged, all right, lengthy treatment to deal with some of this. Kind of just depends on who we're talking about, all right? So candidiasis, sporothrix, and the tenias, as I said a second ago, trichophyton, epidermophyton, and microsporium, and handfuls of species within each of these that can result in these dermatophyte infections, all right? Ringworm, athlete's foot, and other manifestations on various areas of the body, all right? That's the idea. So shifting over to some of the protists, acanthamoeba is a type of amoeba. It's really a pretty common environmental organism. It likes water. It likes water that is cooler. There are other types of amoeba we'll mention later that like warmer water. You've probably heard of some of the brain-eating amoeba, right? Probably. That's not acanthamoeba, all right? So there are potentials for some skin manifestations with it. But really what we think about are eye involvement, all right? Or maybe some central nervous system involvement. That's a topic for a couple of chapters down the road, although we got it all right here, all right? So acanthamoeba is important for individuals that wear contacts because the potential for contamination as they're cleaning their contacts may lend to that amoeba getting into the eye and can potentially result in blindness. There have been numerous accounts of these situations. Contact lens wearers are more susceptible to that, but anybody ultimately could become infected, just dependent upon the circumstances. All right. So here we can see, and with these amoeba, they can form a cyst, a protective mechanism for the parasite to potentially survive some adverse conditions, like maybe it's living out here in this pond and the pond starts to dry up. Forming a cyst can ensure that it can survive until the water is back and ready to go back to the trophozoite stage. The trophozoite is just a broad term. I think I've mentioned this before. It's just an active feeding stage for any of these protozoal organisms. We call that stage when they're feeding, pulling in nutrients, replicating. They're trophozoites. All right. So here you can see the amoeboid form. And one thing that I will point out, acanthamoeba, acantha means spiky. And if you look at the periphery of this guy, there are little, it looks like spikes or little hairs protruding out of it. It's not cilia. These are the pseudopods. And they're almost like little needle projections. Other amoeba are more rounded pseudopods, kind of more of what I think of as an amoeba, with these round projections that pull themselves through the environment. These different looking and giving them their name, all right? So little spikes. And here, this is an individual who's had some sodium fluorescein dye added to the eye to basically test for the presence of acanthamoeba. And this is indicating that it is in there and basically causing destruction, potentially lending to blindness if not treated promptly. Another one, thinking eye, this is a roundworm, so a type of nematode, Loa loa. Uh, about 55 millimeters seems pretty good size to be in the eye. As far as worms go, kind of small. All right. So this worm right here has been extracted from the conjunctiva of the patient. You can see the worm right within here. All right. So these are transmitted by flies taking a blood meal. They inoculate the larval stage of the parasite into our body. Our nematodes, as we see in this image, separate sexes, male and female. They pair up and mate within the subcutaneous tissues. They migrate around. We call these parasites, the juveniles, as they're migrating around. We call them microfilaria. Filarial worms are the category for these guys. The microfilaria in the skin, in the subcutaneous layers as they're migrating around, can get picked up by a new fly, taking a blood meal, and now it's ready to infect someone else. In the process of migrating around, they potentially make their way up into the eye and can lend to blindness in this situation. All right. So they can be detected in the skin through taking a little skin snip and looking for the filarial worms. They can also be identified by looking into the eye. That technically is the end for those, but I feel like no, it shouldn't be. Not if we're talking a little bit of parasites and eye involvement. I feel like we got to talk about onchocerciasis. This type of parasite results in what we call river blindness. It's kind of a similar idea like the Loa Loa. A fly takes a blood meal, feeding on us. It's a different genera, but it's a similar idea. This fly feeds on us, inoculates the larval stage into our body. Same idea. These are also a type of nematode. They pair up, they mate, microfilaria circulating through the body in the tissues, in the subcutaneous tissues, and that fly takes a meal and the cycle is completed. These parasites can get into the eye and result in blindness. And it is definitely a common outcome with this parasite, because we talk about river blindness as the name of the disease. Another one that a bloodless skin snip can show, these microfilarial worms. They add to that slide with the little piece of skin, they add a drop of potassium hydroxide that helps to break down the skin cells, and those little worms will kind of emerge up out of there. You can see them wriggling around. Impressive and disturbing at the same time. So the two, and onchocerciasis, Onchocerca volvulus is the name of that one. All right. That's enough of that. So this next one, respiratory tract infections, the respiratory and the GI tract, I feel like these two body sites are really, when we think about clinical sorts of situations dealing with patients, these are the most common things that we really think about, at least here. If we were thinking about maybe some other country, maybe some sorts of tropical diseases, parasitic infections, maybe they would be more on the tops of our radar than thinking respiratory illness. All right. But as far as things go moving through here, these truly are some of, at least here, some of the big players. Oh man. So lots of potentials for contracting any of these respiratory infections are droplet sorts of transmission, coughing or sneezing, spewing out all sorts of potential organisms. And if you are, if you have a cold, whatever it may be, this is a very good mechanism that is employed to ensure transmission. All right. So cover that up. When it comes to the respiratory tract, we can divide it into upper and lower respiratory tract, and we can talk about separate sorts of infections. Oftentimes, there are potentials for organisms that we may see residing in the upper tract that end up in causing disease in the lower respiratory tract. Just depends on some of the circumstances. When we think about the upper tract, there are lots of organisms that call this area home, a huge amount of normal flora, all right, within the upper tract. And that becomes important if we're really thinking about issues. Careful collection to ensure that you're not just grabbing mouth bacteria or whatever it may be. To ensure that you're really grabbing the culprit is important. All right. And a lot of area within this upper tract where we can think about potentials for people to be colonized with these organisms and for infections to result. And as we move into the lower tract and see an image of that, technically with the lower tract, we think of that as a sterile part of the body. You wouldn't expect, although with human microbiome research, all sorts of things are being opened up. Like we're like, whoa, we didn't know that could live there, right? Or whatever it may be. Currently, our understanding is it's a sterile part of the body, and finding something within the lower tract is ultimately going to be your culprit. All right. Finding something up here, hard to say, right? So I'm not going to go through all of the anatomy of that. Moving down from the upper tract, as we get into the lower respiratory tract, the trachea, the lungs, and the alveoli, areas that should be sterile, but potentially we may find something within that. All right. And we'll go through some details of who and where in just a second. So we talked with part of the innate immunity, mucus secretions providing some protection. We also talked about the ciliated cells providing that motive force to get those mucus secretions and potential microbes that maybe came in there to get them up and out of there. All right. So these pseudostratified columnar epithelial cells are chock full of goblet cells, the mucus secreting structures within these cells, and on the surface of them, the cilia. All right. So here is the lumen of the trachea, and then one bit of those cells, one side of it. If we could move up a little bit, we'd see the same ciliated cells in the cross section. So here's our pyogenes again, and fitting for our upper tract. You can see these cocci cells in nice long chains. It looks like we've got a couple of them right here that are in the process of dividing. And these two right here, we've already divided. Once they've divided, they stay attached, and it makes this kind of chain-like morphology. So thinking strep throat infections, localized pharyngitis, strep throat, We can see at the back of the throat by these arches, the uvula right here. I like to call it you're hanging down, right? The uvula and the arches above it have all of these red splotches. We call this petechiae, as the cells are getting infected with the bacteria, and Pyogenes likes blood. So we're seeing some of that activity with them. There's oftentimes going to be some pus toward the back of the throat, back here, your tonsils, right around here, you might see some of that. And if some swabbing occurs to try to cultivate this, or a rapid strep test, it's back by these arches right back around here that you want to try to collect. Not the cheeks, not the tongue, right back around here. All right. So treatment with antibiotics, important because there are potentials for other manifestations. We talked about some of those type 3 immune complex situations, glomerular nephritis as a result of these complexes from the Pyogenes that can cause kidney issues. We also can see manifestations on the skin, scarlet fever, this rash on the skin. This could have been in the chapter before, all right? So, more potentials. Moving into the ear, we've got a healthy and an infected next door. So the tympanic membrane, the eardrum, and you can see a few of the bones that are going to be transmitting the sound, shrouded by this membrane. As we look at the next one, the membrane has been torn. There's a lot of pus within here, inflammation, some redness, and there's also potentials for deafness to result as these inner ear bones can start becoming eroded through the result of the infection. And numerous players with that. We'll get to that in just a second. All right. This next image looking at the back of the throat, what we're seeing here is called a pseudomembrane. Diphtheria, Corynebacterium diphtheriae is the bacterium. It creates this pseudomembrane. So dead cells, a lot of pus, neutrophils, all of these coming together to create these kind of grayish patches in the back of the throat or in the mouth. Here, lower tract, we're looking at an image of pneumonia. So there are some lesions here, some consolidations, this kind of whitish area and darker bits within there, right? The patches showing the result of the infection. There are numerous culprits for pneumonia. We will get to those shortly, all right? Streptococcus pneumoniae, one of our culprits for pneumonia, is an organism that you oftentimes might be able to find growing in the upper respiratory tract, making up some normal flora, all fine and good. But there are potentials that it gets elsewhere, all right? And in some instances, infections with something maybe like the flu, influenza, if your immune response is weakened, and if your immune response potentially just gets tasked as a result of the flu, you're kind of weakened already. There are opportunities for the pneumoniae to result in these colonizations within the lungs. And now not only are you dealing with the flu, you progress into pneumonia from pneumonia. So electron micrograph of them and then a gram stain. This as we are looking at the gram stain, the purple guys in here are the Streptococcus. These, and as we look at the electron micrograph, typically appear as diplococci, two together. And almost everyone we're looking at, that's what we're seeing. Not big long chains like our pyogenes, diplo, all right? Two of them together, all right? That's the idea with it. Another potential for some pneumonia, Haemophilus influenzae, and I feel like maybe some of the symptoms with this infection could be sort of flu-like, hence influenzae's name. These bacteria need to be cultivated on some specialized media, some chocolate agar. We've described this a little bit previously. It's cooked blood cells, and as the plate gets autoclaved, those red blood cells explode, lysing, releasing all of the nutrients from within the cells, and Haemophilus and some others need those substances. They can't break it down on their own. So very prominent capsule production. You can see the slimy mucoid colonies, the shiny colonies on this plate, indicative of that, and lending to something that we describe as a virulence factor, the ability to enhance the disease process by that capsule layer. Our pneumoniae also has a capsule layer. Mycoplasma pneumoniae is different. It's a different microbe in and of itself. These are really very small. They're very odd bacteria. They are bacteria that don't have a cell wall. They lack peptidoglycan. So they don't gram stain because they don't harbor any of that material for gram reagents to link up to in the first place. Staining for mycoplasma, we do some negative staining. So the India ink or nigrosine to stain our mycoplasma. The fact that they lack a cell wall makes these bacteria also appear to be what we describe as pleomorphic shapeshifters, if you will. They can take on all sorts of different forms because they're not constrained by that cell wall. Mycoplasma pneumoniae causes a type of pneumonia that we call walking pneumonia. You've probably heard of this. Walking pneumonia is something that you definitely feel ill. You feel sick. You feel like, it's a very bad cold, if you will, but not something that you truly feel really wiped out. Likely not warranting going to the hospital. Streptococcus pneumoniae is different, and oftentimes you find yourself hospitalized as a result of Streptococcus pneumoniae infections. But walking pneumonia, probably not. All right. All right. So tuberculosis, these bacteria, we've mentioned the cell wall having the mycolic acid, that outer waxy coating around the bacteria that makes these guys not able to pick up a gram stain. They technically are gram-positive cells. They do have a thick peptidoglycan layer, but you just can't detect it because of the waxy covering, all right? And acid-fast staining provides an opportunity to visualize those cells. So there are all sorts of potentials for this bacteria to try to survive. They can get walled off within the lungs, these granulomas forming these tubercles as we try to encase the bacteria. They also can reside in macrophages that should be killing them. and replicate and avoid immune detection because of that. Lots of things that I think, as far as the bacteria trying to cause disease, some brilliant strategies that they employ to ensure that they are maintained. As they get sequestered away, trying to actually combat and treat these is super difficult. There are potentials that those tubercles open up, releasing the bacteria out for a reinfection to result. It's more, maybe more of a concern in compromised hosts for those situations. Lots of antibiotic therapies require prolonged treatment because of the granulomas that are forming and truly trying to combat it. Tuberculosis is a type of infection that we technically can see around here. It's rare, but you can. Other areas, more common for sure. Other countries, more common. Globally, there's 1.5 billion, maybe a little bit more than that, people that are infected with tuberculosis. That is disturbing, right? And some of these individuals harboring multi-drug resistant strains of tuberculosis. This is a bacteria that we classify as a re-emerging pathogen, something that we felt like we had a pretty good handle on with antibiotic treatment. We could hold this in check. The fact that it requires prolonged therapy and non-compliance in numerous individuals as a result of that has led to some of these super resistant strains of TB and bigger problems. Disturbing. So skin testing is utilized to see if we have come in contact or potentially are infected with that bacterium. And after a few days, if you've got a very prominent welt, this is a little bit of redness, but not anything that I think you would be classifying as a positive reaction. I looked through here. I'm like, I don't think that's positive. You would know. All right. It would look more like this, but very red and nice and swollen up. You're going to see a little redness, but yeah. All right. So with our bacterial infections, otis media, so acute otis media, this is inner ear, not the otis externa that we talked about in the previous chapter. So a lot of organisms that we think about potentially living in your mouth can potentially make their way up there, up the eustachian tube. Haemophilus, strep pneumo, moraxella, and some others can potentially cause these issues. Lots of problems with this, and little kids sometimes get a lot of ear infections as a result of some of these, and it can be just some of the colonization as they're starting to get all of that occurring. The ear infections become very common, and sometimes tubes in the ear to help drain that can be warranted. There's also issues with some biofilm formation. All of those very mucoid colonies makes it difficult to get those drugs deep into that biofilm and really combat it like we want. So the diphtheria, that pseudomembrane Corynebacterium diphtheriae, it can cause some serious issues and maybe even lending to suffocation as a result of that. Legionnaire's disease, Legionella pneumophilia, we saw the littlest hint of that previously. This bacteria really rather new on our radar, so one that instead of our TB, a re-emerging, we would call this an emerging pathogen. First recognized in the 1970s, which to me doesn't seem like that long ago, but an eternity. right? So pertussis, whooping cough, Bordetella pertussis is the bacterium, and the coughing fits are prolonged, and months of these issues with this. All right. And if we're talking little dudes, this can be a fatal infection in an infant. All right. So vaccination, important. And we can see a handful of these for vaccination. The DTaP, diphtheria, tetanus, and pertussis is our DTaP. And then there are potentials for it to not have all of them. But typically, childhood vaccine DTaP for diphtheria, pertussis, and tetanus. That's not in this chapter, but they're all grouped into this one vaccine. All right. So Q fever, we didn't see this, but Q fever was called this for query, for question mark, because we flat out didn't know what the hell's causing this, right? Super high fevers and coughing, pneumonia, malaise, you just feel like crap, and maybe fatal endocarditis. So we ultimately figured out the Q. All right, Coxiella burnetii is the culprit. We think about it as kind of a zoonotic infection. So aerosols of urine, feces, or milk, amniotic fluid from livestock, cows, sheep, and goats have the potential to harbor the bacteria. So ranchers have a greater likelihood of developing this, right? Or maybe veterinarians as well. So strep we saw, and TB as well. A little more chlamydial pneumonia, chlamydia pneumoniae, cysticae, and trachomitis are all chlamydiophilia, our first one, and then chlamydia for these next two. The cysticae, this one is important with birds. Pigeons, I think, are one of the bigger players with this. So bird feces is a potential to contract that. The others were thinking about respiratory transmission, droplets, aerosols, and the trachomitis. This we're thinking about fresh hatchlings. So in transit through the birth canal, if the mother is infected with chlamydia, the newborn, as they are coming into the world, has the potential to aspirate some of those organisms and result in pulmonary infection with that. So just depends on those circumstances as far as how you're contracting it. We saw the Haemophilus, coughs, fever, low body temperature, so not a fever, chills, chest pain, headache, and fatigue, kind of flu-like, right? But typically with the flu, we're thinking fever, right? Klebsiella pneumoniae, this is a bacterium that's also a super good capsule producer, another virulence factor. It is just naturally multi-drug resistant, so antibiotic therapy is super difficult with these guys, all right? It causes lung necrosis, current jelly sputum, so as you are hacking up that sputum, it's tinged with red speckles. The destroyed red cells, as it's breaking down the lung tissue, are hacked up, all right? Crazy. Mycoplasma, low-grade fever, persistent cough, and like I said, it's a little, as far as some of the pneumonias go, a little more mild, if you will. All right. Our pneumoniae, Streptococcus pneumoniae, strep pneumo, productive cough, bloody sputum, fevers, chills, chest pain, and potentially respiratory distress. There are some vaccines available for this. The numbers here tell you strains. There are boatloads of strains of Streptococcus pneumoniae. So 13 different varieties or strains with this one, and 23. And these are all different little fragments of the cell that the vaccine's able to be generated against. And lastly, Pseudomonas for pneumonia, Pseudomonas aeruginosa, another super good one for capsule production, very viscous fluid, thick mucus secretions, chronic inflammation, and potential fatal outcomes. This is a very good bacterial infection, or a very bad, I should say, for individuals with cystic fibrosis. It can get in and colonize, and if it does, it is very difficult to truly try to get it out of there. So definitely an issue. This was one of the bacteria shout out for the C-phage stuff. Early on, some researchers dealing with bacteriophages were able to find a virus against Pseudomonas. And there was a patient with cystic fibrosis that they were able to utilize phage therapy to combat her infection. Pretty impressive. All right, I will quit with that. We will pick up with viral stuff Friday.